We'll see who our audience is today, whether it's on the YouTube or LinkedIn, but it's definitely a struggle. All right, let me read this transition statement. Before we talk about staffing and policy, we must address the metric under every other metric, hope. Healthcare has always been at its core in the business of hope. Patients do not come to us for data alone. They come because they believe that a better outcome is possible. When clinicians lose that internal sense of possibility, burnout, and moral injury do not simply affect performance. Um, they erode identity, relationships, and the ability to remain in the center of hope. Hope is not a slogan or a soft skill. The business of hope treats it as an operational infrastructure, something that can be measured, practiced, and built into how teams lead, work, and recover from what they carry. The Hope Assessment at hopeassessment.org gives clinicians a structured way to see where their hope stands and to begin a recovery process that does not depend on the system changing first. Completing it is not just another survey, it's the first step in an organized path from exhaustion to hope. Hope does not replace policy, it powers it. The reformers we will discuss today, including staffing, legislation, and culture, will only succeed if the people at the bedside have enough hope to advocate and to stay. So with me is Ashley, my business partner, and we created the business of hope. Ashley, talk to me. Where are you at today?
Oh, great question. I'm coming in today at a 7 out of 10. How are you coming in today, Matt?
Oh, good. What we do is we look at the sticker and we decide based on the 1 to 10 scale. And I feel like a 7 or an 8. I feel like I'm stable and growing. I feel like when you lead something like this, you're thought of and expected to be a 10, but like, I still have my anxiety and I still have my concerns. Obviously, the technical, I'm not there. And I never pretend to be, but it is a little bit on my emotional side. I feel like there's a great purpose for today and meaning, and I'm just so excited. Ashley came to me from Florida by way of Alaska. So, like, she's been all over the country. And it means a lot that she's here physically present. So, the business of hope is about that check in. You do it on your own in the morning before you go to work. If you look at it, there's a crisis level at the bottom, the red. We have a little paper that we give out at our live events that kind of explains it. Crisis and overwhelm could mean a lot of things. It can help. Some people, have gotten so bad that they're suicidal. Other people are just so bad that they can't work. 1 to 2 is really just that spot where you need yourself. Ashley really talks about it well when she talks about, did you get your water? Did you get your sleep? Did you, what did you do for you? So, do you have anything you want to add about it?
No, I think that 1, 2 is exactly that. We need to care for ourselves, and then we need professional assistance in one way or another, whether that's a physician or a spiritual leader, a director, your psychiatrist, your therapist, anyone who can help you, that's what you need.
Yes. We'll probably come back to this. It's 10 o'clock and Robert Wingo's here, and I want to admit him and start that conversation. Is that all right? Okay. Robert, did you accept him?
Did.
All right. Uh, let's see. I see him and I'm trying to highlight him. Robert,
Hey, Matt, good morning.
how are you?
I'm fine, thanks. How are you? You've got a big day going today, don't you?
I know. We had a little technical difficulties, so we ended up starting late, but I'm going to add you
Okay.
here. And everybody, I mean, we're here, so I'm going to do a little intro for everybody listening. Our next speaker is Robert Wingo, and he works at the intersection of where financial and staffing decisions turn into real conditions for patients and nurses. The book, How Healthcare Dies, shows that when staffing falls below safety thresholds, missed care, preventable deaths are not random. They're predictable outcomes of deliberate decisions. And Robert, he's going to speak to that truth and what he believes must change. So, Robert, give us an intro about what you're working on.
Hi, Matt. Thanks. Good morning. And I just want to say congratulations on your book launch. I know this has been a long time coming for you. We've been talking about it for a while. And you've assembled just an incredible volume of the evidence that's out there. You know, all of the peer reviewed and all the studies and everything. It's a very sobering account of what's happening in healthcare. And like you alluded to it in my work, one of the things that Matt traces is sort of the evidence. What happens when all of these decisions are made in healthcare with these like financial failures. And it's actually sort of the mirror piece to a lot of the work that I've been doing. I've spent years documenting, one piece of this problem, and it's on the workforce planning side, and that there's a budgeting formula that's used all across the globe, and it's the most popular nursing finance approach to calculating budgets, and it understates what the staff that a unit needs before the year even begins. And so the unit gets set up short on that on paper, and then the people are asked to absorb the gap. And Matt, the thing that I love about your book is you've done such a fantastic job of documenting what happens on the other side of that. Once this flawed approach to workforce planning and management is implemented, what is the outcomes of that? And like I said, you've done such a wonderful job of compiling a lot of the evidence. I just want to say thank you, and I'm so glad that your book's finally getting out there.
Thanks, Robert. Yeah, it took me a while to just understand your research. And like, I consider myself, pretty good at that. But like, once the light bulb went off, I reached out to you and I was just like, oh my goodness, like what? And I think it's worth it. It's worth people spending the time to really ingest it. And it takes time, I think, to really understand it because it's like it becomes the elephant in the room because I think people don't
It
always
really does.
acknowledge it. The first math problem was simple. It was like, do we multiply or do we divide? And that's like what we call it sixth grade math, you know? It wasn't complicated.
Yeah,
But
absolutely.
once I understood, um, like in every other scenario, you know, that's what I would do. I'm like, I needed that.
Yeah. Yeah. And the thing about it is I'm so glad that we ran into each other at just the perfect time for all of this.
Yeah.
Um, it's, it's, if you, so of course, I was a nurse in the late 1900s, as I like to say. And, I don't know if you remember that back in like the 80s, the old Reese's peanut butter cup commercials. Hey, your chocolate's in my peanut butter. No, your peanut butter's in my chocolate.
I
And it was
know.
kind of that. It was kind of that same feeling with our work. It's like, holy cow, man! What's going on here? And
Yeah.
once you understand, when you look at both sides and what's happening on each side, from the finance side and the impact that has on the resources that are available and that our nursing leaders are struggling to provide care with what's being given. And then you look at the body of the nursing research, right? All the evidence-based practice, all the nurse-sensitive indicators, all of the things that can be tied to the quality of the care that's being delivered, and the negative impacts that it has, personal and financial, and et cetera. And once you kind of understand a little bit about both sides of that, it really starts to make sense. A lot of people, one of the things that I'm kind of concerned about, and one of the things that I love about your organization is that there's hope out there. There is hope. And the hope lies in understanding how the business of healthcare is delivered, and how the way that we deliver it uh, impacts people, impacts the caregivers, impacts the patients, and impacts the families of both. I think that's the thing that a lot of people don't understand. We talk about burnout, we talk about moral injury, we talk about um, poor patient outcomes, all of these negative things, and there are really three parties here that are being affected by this. You've obviously got the nurses that are struggling at the bedside to provide the level of care that they would like to, but the system often doesn't let them. You then have the patients who end up receiving that less than optimal care because of the way the system is constructed. But then the thing that gets lost in all of that, I think, is the families and the loved ones of both of those. You've got the stressed out nurse that goes home and maybe they're short with their kid or their spouse or whatever. You've got the family members of the patient who maybe there's a bad outcome or an adverse event, and they're having to deal with possibly long-term effects of their loved one and so forth. And so this is an issue that really does impact everyone, because at some point all of us are going to need the healthcare system. It would be extremely rare for anyone to go throughout life and not have to be in the hospital at least once. So this is something that's going to impact us all. And again, just thank you for your work and your diligence and thoroughness in sort of compiling this volume of all of this evidence that points out, what happens when we don't get it right. But like we've talked about before, we have an opportunity. On my side of the research, it's a math problem. Math problems can be solved. And if you get the math a little better up front, if you follow the literature and all the theory and everything, if we do a little better job on staffing up front, we should have fewer of the problems and stuff and negative effects that you've documented in your book.
Oh, thank you. Yeah, and for people that haven't read the book yet, there's an entire section called the 4 Pillars of Death, and one of those pillars is just the I guess the psychology of it, where and then there's 2 of them basically, but then there's one that talks about the hospital losing its sense of meaning, and it's there to save people, and yet the people in there they don't believe that. And then the last one that I want to talk about is the one that Robert is referring to, and it's probably the most researched chapter in the book. And we talk about how the finances eventually explode on themselves, and separate from staffing, which I know that's Robert's focus, but they've tied executive bonuses to financial performance. And you think about that, in a hospital setting, like if you're making cars, right? The more number of cars you sell, the more money that CEO should be earning, right? In a hospital, it should not be profits. I would say the more lives that we save and the more people whose lives are better as a result of being in the hospital, we should celebrate and give executive bonuses to those people in those positions. But that's not what's happening. The hospital systems that extract the most money, that harm you by how much they understaff and everything, those are the ones that are getting more bonuses and pay. And it's I think that's shocking for people to hear. They think hospitals are benevolent and they're just saving lives, but so many decisions are based on profit margin now, and it's your life.
And Matt, one of the things that I would like to speak to about the whole profit issue is, and there are probably a lot of people that aren't aware of this, that in nursing is the only profession in the hospital that can't bill for their services.
Right.
If you go into the hospital and let's say a respiratory therapist comes by your room, a doctor comes by your room, occupational therapist, somebody comes to draw some labs, you get your hospital bill, you will get a line on your bill for each and every one of those encounters. You will not find on your bill a charge for nursing services, because back in the 1930s, when hospitals started to become big businesses, they rolled nursing services up into the daily room charge, just like hotels do with housekeepers.
Yes.
And as a result, when you start looking at profit and everything, that sets up nursing as a line item cost. It's an expense. They don't generate any revenue. So finance looks at it as a resource that needs to be cut, constrained, and managed. Needs to be as lean as possible. And that mechanism is actually one of the biggest barriers that we have to things like, people like to talk about nurse to patient ratios
Yeah.
because of the way the current reimbursement structure for nursing is structured. Um, that's a huge barrier because it doesn't really allow us to um, fund the positions that we would need it to really staff to these mandated ratios. The
Yeah.
other issue is it's also a barrier to hear a lot of people talking about they want to staff to acuity. If we have more patients that are sicker and more involved, we would like to add more staff. The way the reimbursement rate works, it doesn't allow us to create a budget to account for these patients that may require more attention and more
Yeah.
care. Um, and so that's one of the big things that I think is really driving a lot of the problems that we're seeing in healthcare. Because when you go into the hospital, why does somebody go into the hospital? It's because they need nursing care. They need monitoring. They need treatments. That's the only reason you go to the hospital. Otherwise,
Yeah.
you would go to an ambulatory surgery center. You go and have your surgery and go home,
No. Yeah.
right?
Yeah.
And so, yeah,
I think that's a beautiful statement because when it comes to, the reimbursement rates for nurses, you won't find that because it's just part of the bed cost. And it's like
yeah,
you said, it's part of housekeeping. But like the other thing that the book talks about is the ratio from like anything above 1 to 5. If you go 1 to 6, it's like a 17% increase in the possibility of that patient's death.
yeah,
And hospitals, it's in the book, hospitals save an average of $92 by pushing staffing margins above
mhm,
5 to 6,
yeah,
7. I know hospitals right now that are running 8 for med surge. And like, I can't speak as intelligently about ICU, but like my understanding is it used to be 1 to 2. And for a really critical patient, it's 1 to 1, which is pretty rare. But like some ICUs are pushing 1 to 3 again. And it's like,
yeah,
how can you monitor so deeply? And the cost savings on that is, I got it down to 96 is what I put in the book because it's ridiculous. And the cost, it becomes a patient safety issue. And it could affect your harm score if it was ever thought of that way, because
mhm,
an overworked nurse has at least a 17% more chance of that patient dying just because of your ratios. So
yeah,
it's not so much about a cost metric. It should be thought of as a safety intervention, and the end of the book is just over it because in California they have a floor. It's called a staffing floor, and the law is 1 to 5, but most California hospitals operate at 1 to 4. And the the language they used when they created it is what I've imparted, and I think it needs to be a staffing floor that that
mhm.
that every hospital should be doing it. And it's like, and it should be public. Like if you're not doing it, like we go somewhere else, you know?
Yeah. Well, and one of the things I would like to mention about the floor and the ratios, everybody, thinks ratios are such a great idea, but when you go back and you look at the current reimbursement model,
Yeah,
ratios can create a problem. And this is one of the other reasons why I'm so glad you put your book out with all of the data.
yeah,
We have an opportunity, and if we're going to solve these problems in nursing and healthcare, we as nurses, we have to return to our roots. Our roots as data scientists. If you go back and
yes.
you look at what Florence Nightingale did in Crimea, she went down there and she looked at these absolutely deplorable conditions, and she took a data scientist approach at it. She
I
looked
love
at the
that.
environment. She looked at what was going on. She collected all of her data and figured out it's like, wow, we've got more soldiers dying from infections and stuff in the hospital that are dying in the battlefield. And she came up with a plan and she implemented it, and she saved lives. She saved many, many lives. The
Yeah.
things that Florence came up with, so long ago, they're still saving lives today. And we have that opportunity right now in front of us as nurses to take this data and to stand up and say, we need to use this data to figure out how to save lives of the patients, and also, save lives of some nurses. You've got some nurses that show up in the news occasionally due to moral injury. Sad to say, they end up taking their own lives.
Yeah.
And so we have this tremendous opportunity in front of us to take the data and do, instead of, nursing likes to talk about evidence-based practice. And so, in my model, that's the loop between where you do your scheduling to staffing, and then looking at your outcomes. It's that loop. What care did we provide, and what was the outcome? We need to expand that thinking. We need to start thinking in terms of evidence-based management, where we go all the way back to starting with our reimbursement model. How does our reimbursement model constrain what we're able to do at the bedside? How
Yeah.
do these errors in the budget filter up through position control, scheduling, staffing, and ultimately impact our outcomes? And again, I think I just can't say enough about your book and just the incredible volume of evidence that you've collected and organized to help tell this story. It's just going through it and sort of chapter by chapter and looking at everything that you've assembled. How can we look at all of this evidence, all of this data, and not do anything with it? And I think that's the wake up call that we need to give nurses, that there is hope, and that hope lies in the data and in us understanding how the way we plan and manage our care environment, the way we plan and manage our resources, is what is that data is the result of how we do that. And
Yeah.
so we need to go all the way upstream. We need to go back to the beginning, the root cause. We like to talk about root cause analysis when we have like sentinel events and all this stuff.
Yeah.
Well, I would say that the current state of healthcare is this massive sentinel event in progress right now. We
Yeah.
really need to we really need to get upstream and look at these root causes and figure out what can we do about them, and how do we set those things in motion to begin correcting some of these problems.
Yeah. Oh, it's perfect. I want to thank you. I want to thank you for reading the book and buying the book. And really, more than importantly, I just hope it helps to start conversations like this where somebody else is working on an aspect of it. I don't think of myself as the best detail-oriented person, so sometimes I get lost in those numbers, but it was important enough for me to figure this out because, like, understanding money really helps you understand the flow of everyone's consciousness inside of it. So I just want to thank you because you've taught me quite a bit. I shared the chapter with you and tried to get some feedback, but it's not like you handed me a script and said, go here. You were like, I think you gave me like two other resources or something. I was like, that alone gave me some validation because I'm dipping into the deep water and it's like
Yeah.
I didn't want to choke. So I just yeah, you're part of why the depth in that chapter exists. So
Thanks so much, man. I'm glad like I said, I'm glad that the timing worked out and we just kind of ran across each other at the right
yeah.
time. It's just crazy. It's just crazy.
Well, I just want to finish this closing saying that safe staffing is not a perk for nurses. It's a minimum ethical standard for any hospital that claims to provide care rather than quietly budgeting for acceptable loss. And I think, Robert, you embody that, and I'm just so grateful. And if you ever need anything, I'm here for you, all right?
Yeah, I appreciate it, man. And you know what, Matt? I actually have one question for you I'd like to ask.
Oh, please, please.
In your book, of all the failures that you document, which one would you say is the most fixable in the next few years, and where should people start with it?
Oh, that's a good question. I get that a lot. Like, what's the what's the most important thing? Now, if you ask me, I think the most important thing is truth, right? And there's a huge movement in Indiana specifically about transparency. So if a hospital system were just transparent and honest about, the cost and the money, and then we had an open system where you could choose A, B, or C hospital, right? You would just
Mhm.
go to the cheaper one. You would go to the one that has the best quality, and to save your life, but you would also not go to the one that's going to charge you so much. Like the very simple breakdown was like on MRIs. You can go to an outpatient center and pay $500 for an MRI. That very same MRI can be done as an outpatient inside a hospital and cost you over 3,000, right? Just
Yep.
just having that truth, just having that knowledge is the first step, if you ask me.
Yep. Finding that good balance between value and quality.
Yeah.
Value, and again, to do that, we've got to have the data. We've got to get the data out there and have people that can, uh, help make sense of it for consumers. And again, you've just provided another excellent example of why we need nurses that that are going to be really interested in getting back to those data scientist roots, because that's what healthcare really needs right
Yeah. Yeah. You know, there's so much that's wrong, but like I always start with truth. So
now. Yep. That's a great place to start. Great place to start.
I appreciate you, Robert. Anything else?
No, I just, thanks so much for having me on, and again, once again, congratulations on getting your book launched. I hope that people will pick it up and read it. I hope people will reach out to you for the work you're doing, um, and all the things that you're trying to get out there. That there's hope. And again, congratulations, Matt. So happy for you.
All right. Thank you, Robert.
All right, thanks so much, Matt.
All right. Bye-bye.
Bye.
All right, we're going to take another little pause. Our next speaker, it should be here in just a few minutes, but I'm going to hit pause on my Hello again. I'm back. It's 10:30. Um, Still waiting on our next guest, but I thought I'd come back and talk to you. Um, so the book itself has already done well. We launched it quietly June 8th, and I just thought it would be an opportunity to test it out, make sure the linked work. And people started buying the book. Like I kind of told everybody to wait till today, and people didn't. So what's funny is on last week it hit the bestseller list. So it's like pre-launch, we were able to celebrate what I was hoping to celebrate at the end of today. But um, I'm humbled. I spent all this time on a project, and I think a lot of people that know me saw that I was doing that, and it's just been a process for me. And the more I see that the book is returning to people watching it and reading it, just the more humbled I am that I guess, the work I've been doing matters. It's been about finding language. It's been about finding ways to communicate. And I kind of get welled up when I think, wow, I've done it. I'm trying to bridge the bedside and the boardroom, and trying to understand systems and some of the people along the way that aren't here today. Just some of them I want to acknowledge. David Dibble was there to talk about systems and how we bring love into the mix. I'll talk more about it, but I want you to know our next speaker is here. So I'm bringing him on. Todd Otten. I admitted him. Todd, are you there?
Had two links and I wasn't sure, and I'm
Sorry.
sitting in my car, so I sorry.
No, I'm going to spotlight you. There you are, Todd. All right. So I'm going to do my own introduction. Our next presenter is Todd Otten. He's addressing a culture that many clinicians know, being told to suck it up. Instead of having unsafe conditions changed. The book and How Healthcare Dies is about burnout and the distinguishing it from moral injury. Burnout can be eased by rest, but moral injury arises when clinicians are repeatedly asked to act against their values and then told to call that experience resilience. I know Todd's work, and he's going to speak on that distinction a little bit. He's going to give us some insights as to what he's doing in response to it all. So, Todd, you have the floor.
No, can you hear me okay?
You're perfect.
Well, first off, congratulations, Matt. I think your book is brilliant. Um, I've had the honor of being asked by a handful of individuals to read some books over the past couple of years, and honest to goodness, yours was one that I just couldn't put down for the most part. So, well done, sir. Well done.
That's
Yeah, I
great.
suppose I'm a bit of a positive disruptor in some capacities. Got my hands in a few different pots these days. Um, the project Matt was talking about the most was the documentary "Suck It Up, Buttercup." And ironically, originally when we had started with the project, the two physicians involved in the group, myself and Marianne Wilbur, neither one of us were thrilled with the title
Yeah.
originally. We had some hesitation. I think I came around a little bit sooner, perhaps. But ultimately, I feel like it landed in the right spot in the large degree of what you're talking about. Whether we're talking about burnout or moral injury, I mean, pretty much everyone in the healthcare delivery system in the United States is being asked to suck it up in some capacity, whether it's financially, whether it's time, whether it's caregivers, whether it's nurse to patient staffing ratios. The list goes on and on and on and on. And it has to change. I think just about all of us have experienced some capacity of burnout in our career, um, emotional fatigue, lack of compassion, lack of value in work, anger, frustration. I distinctly remember sitting in my backyard, hating the job that I had always loved. in tears. And I didn't go into medicine to go home upset and scared and sad or what have you. Oh boy, and I hope my battery doesn't die, mad. If it does, I'm gonna have to flip over to my phone.
Okay.
So burnout is a symptom of our broken system, right? That's we're scapegoating people. The reality is we've got much bigger problems that are much further upstream, which your book brilliantly highlights, and around the concept of moral injury, where we're being asked to do things, but we don't have the resources, we don't have the access, we don't have the finances. There's barriers, there's prior auths. I could go on and on and on about all this stuff, but I probably have spoken too much already, so I don't want
Oh,
to
no.
steal the floor or what have you.
No, Suck It Up Buttercup is doing well. Were you were just recently in Portland and you sold out, right? At your
Yeah,
showing?
yeah. So, oh boy, I was on a little bit of a whirlwind tour recently. Went to Aspen, did a TV spot. Then we went to Portland. The theater was sold out. About 300 people were there. The Dr. and Lady Glaucomflecken were in attendance. We had a Q&A afterwards, which is incredible. And I'll just give one example of a win from that event. um, the film is intended to really pull the curtain back for the American public how greed is destroying our landscape, right? From the voices of a multitude of stakeholders. Obviously, it's physician-led, so there's a fair amount of physician voices. But I see a friendly face and a nurse on this call that perhaps
Yeah.
is in the film as well, amongst a handful of other nurses and patients and some celebrities and what have you. Um, but with the twofold call to action that I think some of it's individual, unlearning learned helplessness, that notion that I'm just one person, what can I do? Well, excuse my French, but I was in the Navy. Bullshit. Your words matter, your
Yeah.
actions matter, what you do day to day matters, right? And so we've got people that are just trying to survive their day, and the hope is to educate not only clinicians but patients to feel empowered to get involved and do something. So that's really unlearning their helplessness. But then the second part is accelerating an impact network, connecting dots of all these disparate groups that aren't working together, aren't collaborating to start to do so that we can move our efforts further upstream. But there was a long-winded discourse on the one example that occurred at the end of the Q&A in Portland. An interventional cardiologist stood up, introduced herself, and said, I'd been debating opening another clinic to improve access in the area, and this film inspired me to do that.
Oh,
And I'm like, if that's all we got out of today, then it was a win. It was a
yeah.
win for this community. You know what I mean? So,
Right. And I think that's important about the work that you're doing. It's like you're identifying the problem, right? And then you're offering hope as a solution. Like sometimes I think people offer solutions that work in their minds, and I do the same thing. We all do. But it's like the solution is part of this collective whole. And as long as we're bringing all these people together, we're going to find solutions that we didn't even think about, and that's what wakes me up in the morning is like, what am I going to learn today that I didn't know yesterday? Or what am I going to find to be a part of that I wasn't already? You know? And when
uh,
you start looking for that in those other groups, it's amazing what's out there.
man, I agree with you. I think, and that was when we were debating the calls to the action for the film. That was one of the biggest sort of pushbacks I got very early on in the process. Like, what's the call to action? It needs to be very granular. It needs to have this timeline, 3 to 6 months or whatever. And I kept thinking, like, we're not going to fix this in 6 months. We
Right.
might not 6 years, maybe 60 years. I don't know. We
Right.
need something. I felt we needed something that was going to be relevant for many, many years. Right.
Yeah.
And we need to think differently. And I agree with you. I think there's solutions out there that we haven't even thought of, probably from circles outside of healthcare. Right.
Yeah.
So it's exciting. I mean, the momentum behind the film is continuing to build, and we've actually set it up that if people want access, all they got to do is throw a couple bucks at our GoFundMe to support the distribution, and they're going to get a link. So if you want to watch it, you can watch it, and you don't need
Oh,
to spend a
good.
fortune to do so.
That's good. Well, yeah, and you can put that link in our chat if you want people to go to it. That way, people, I know people will. I know I will.
Well, I will find it.
No, I appreciate it. The I think you said quite a bit about the book and really what you hope for. Do you have any questions or any comments or anything else? I mean, you've given us a wealth of knowledge.
As I'm trying to multitask with the GoFundMe, and I'm
Oh, I'm
old,
sorry.
so no, that's okay. You know, yeah, actually, well, I want to ask you a question
Please.
about your book. What what was the inspiration? What was the why? What drove you to write the book?
Well, I had my own personal kind of breakdown when it came to healthcare during the pandemic, and I think a lot of people did. But what really struck me in my practice is I spent 10 years in a psych hospital, and you expect a psych patient to commit suicide. That's why they're in the hospital. But I never recovered from my coworkers that did the same. And I could name them. And I guess I wanted a voice and I wanted tools so that maybe that never happens again.
First, Matt, I want to say my condolences for your losses. I think most of us have had that experience in some capacity or another, or tangentially know someone at the minimum, and it's heartbreaking. I actually had a meeting this morning with a colleague who is on the insurance side of things, but looking to be interestingly being disruptive in that capacity.
Yeah,
And he told me, he's like, I had no idea. He's like, I had no idea the suicide rates were what they are for clinicians.
right.
And I said, yeah, it's bad. And it's like, we talk about Wendy Dean talks about canaries in the coal mine, and as a physician, she's obviously alluding to physicians, but this hits
Right.
every level, right? I
Right.
mean, oh,
But you have physicians have a another level. Like when you re-up your license, you have a questionnaire or you have an expectation to put on this um you have to document that you're mentally stable. Like that's part of your re-license requirements, is my understanding. But like nurses, we don't. And I think that adds a different level of stress. I think physicians already live in a different level of stress. When I got into healthcare, that was one of the first things that blew my mind. I thought being a doctor was the coolest thing, and then I found out these doctors, a lot of them are on call, so they have a separate bedroom in the basement, so they can get calls every like 10 minutes. Like, and they never sleep for a week. And you think about residency, and you just all the pressure that's put on them. It's like they can make all the money they need or want. Uh, I'm never, I'm never signing up for that job, you know?
yeah, Matt, you're right. I mean, it's a commitment, going to, and we all make a commitment to one degree or another too. But I mean, I think about my colleagues. You think about after high school,
Yeah.
two things come to mind. Betsy Gall was in the film, and she lost her husband on Thanksgiving Day.
Yeah.
And she says you think about the years of training. He went to school for 15 years after high school to do what he
Yeah.
did as an oncologist. 15 years. I mean, you
Wow.
were sacrificing your 20s and
Yeah,
most of,
you do.
half of your 30s, to train to help other people. And I don't think a lot of people realize the level of commitments that's there. I mean, even in my own experience, I had the pleasure of having 1 year of residency before the 80-hour work week restriction,
Yeah.
right? Um, and so I counted up my personal record for hours in the hospital,
Yeah.
126 hours in the hospital. I think there's
Wow.
168 in the week, I think.
That's
Um,
amazing though. Like I can't imagine. Like, and sometimes when your doctor is a little short with you or curt, it's like, they might have been on for 3 days. It's amazing. So I get sick at 12, 10 or 11.
Yeah, thank God those days are gone. I've got a lot more gray hairs and a little bit more control over my schedule now. But
And
um,
yeah,
go ahead.
the one thing I want to say about Todd, for everybody listening is like, you always hear about experts and people that are doing things, but Todd, still works as a physician and, he sees patients. And like, I think people, that get into this reform thing or game or whatever you want to call it, they get to be consultants and they talk about practice. But like, when was the last time you saw a patient?
Yesterday?
I'm just saying, in my mind, that gives you credibility. I saw patients yesterday too. And it's like, you know, we didn't leave the bedside for everything that we're saying and for everything that we're doing. Like we are still there trying to make a difference. And that's what I really love about you, Todd. So
Well, thanks, Matt. I think it's. I have a couple fun roles, beyond the advocacy work and in the documentary. I have two roles that I have. One's with a group called Emergency Care Specialists, which is a emergency department physician group in Grand Rapids, which is where I'm at now,
yeah,
getting ready to do some outreach. But I'm kind of like a built-in consultant with them. They do amazing work.
yeah.
Nearly 200 physician ED group. Think outside of the box, embody the quadruple aim, all that kind of stuff. They're kind of a unicorn if you think about it. And then the other role I have is with Plum Health doing direct primary care, which is the role I was at yesterday. And then
Okay.
we'll be there for the rest of the week because,
Oh,
but I see like 10 patients a day. So it's
that's
like,
pretty good.
it's awesome. Like I can spend as much time as I want with people, and dig into their issues and help them navigate some of this chaos
Right.
that exists. So, um,
Perfect.
well, and you talk about back to you, though, Matt. If I may, you talk about one of your solutions is community-based care. At the end of the book, which I think is brilliant, and I
Yeah.
completely agree with you that we need to figure out how to get this on the local level at scale.
Yeah. And I think, communities have the opportunity to take ownership and, we don't necessarily need to open a hospital tomorrow, but I pulled in the ideas that I'd received from all these movements about public utility models for, healthcare. And I just took it the next step further. Like if we want to treat, healthcare as a utility, then why doesn't the community own it? You know? Like that's what they do. And honestly, I think if a hospital really wants to change, like they need to change their board. Like there needs to be a nurse invited and there needs to be a community member invited. And they need to be full, active, participating members of their boards. If not, we need to find ways to fund alternatives because hospitals are not there to be sovereign. They're there to be servants of the people. That social contract for medicine, it allows, doctors and nurses, the ability to perform miracles, but with that, you have to serve your community. You can't just extract and extract and extract. You have to be a viable, uh, you know, member. So I asked Ashley here just because I know, she's part of this, and I just want to make sure she has a chance to ask you any questions, and then a time is good. We'll let you go. Ashley, you unmute. It's your chance.
Hi, thanks for being here, Todd. Thank you both for what you do and your advocacy in this space. Todd, I'm curious to know, outside of Suck It Up Buttercup, what else are you working on?
Oh boy, how much more time do we have? um, so the nonprofit that I do the most work for is with Medicine Forward. And Medicine Forward recently just switched its mission statement to catalyzing positive change so the patient clinician relationship can flourish. It used to be patient physician, but we wanted to be much more inclusive. Um, Medicine Forward is a fun group of positive change agents that um, organizes in a decentralized fashion. So there's a lot of room to experiment and be flexible, etc. But I would say I'm tethered to multiple other nonprofits and trying to help with thought leadership or uh, getting their voice out there. The Patient Revolution is one, the Healthcare Reinvention Collaborative is another one. The Lorna Breen Heroes Foundation is another one. And granted, I'm not like doing everything under the sun with these groups, but they'll intermittently call and say, "Hey, do you want to do this podcast, or do you want to do, can you speak up here, or do you want to go do a TV interview or whatever?" Which I never thought I'd be doing that kind of stuff. So it's kind of a smorgasbord of things. But I think the point to that is like there's something for everybody. The Committee to Protect Healthcare is another one. They're doing some amazing work more on the legislative side of things. I went to their organizing summit in Chicago, and they're looking to have chapters throughout the country, trying to really advocate for different either policies or individuals that are going to get us to a better place with healthcare, further upstream. So all kinds of fun stuff. I've gotten a little bit better at saying no as well. And not saying yes to everything under the sun. And before I forget, your hair looks great, by the way.
Thank you very much. I love that you said saying no. Something that Matt and I are very passionate about with our business of hope and the hope scale is not only getting back to the self-care, making sure we're taking breaks and feeding ourselves and drinking and hydrating, but setting healthy boundaries. Saying enough is enough. This comes from that caretaker role, the people that are overextended inside the hospital and beyond the hospital, but even just saying no to the overtime or no that we're not doing that. Boundaries are so healthy. And I think when the community and patients see professionals, see their physicians, their nurses setting boundaries, that is an example. And it's really healthy. So thank you for that, Todd. I appreciate you so much.
Oh yeah, likewise. It's great to see you, and then great to be here. And again, Matt, I think your book's incredible. So I can't say enough about it, honestly.
Good.
I loved reading it. I hope you sell a bunch of copies.
Thank you, Todd. Thank you so much. And I just got a little closing statement, and then we'll say goodbye, okay?
Sounds good.
Every time systemic harm is met with another resilient slogan instead of a structural change, clinicians are taught to blame themselves for wounds that the system created. Today, we're choosing a different story.
Well said. Well
All
said.
right. Anytime you need me, I'm here, Todd. Thank you.
Sounds good. Thank you for having me. It's great to see both of you, and happy Tuesday.
All right, you too. Bye-bye.
All right, see ya.
All right, Ashley, we are going to take our break. It's 11. We are set to be back here at 2. So we have another speaker scheduled there. We wanted to turn off the camera because we're about to have a community event. We have a number of people coming to this event, to this venue, and we're going to talk about a coalition. And what this is the real work of the book. As much as I like praise, everyone does, the book is good. The way I want to measure success is, did we actually change something? So in Indiana, we're starting with this Fountain County Healthcare Access Coalition. And it's a small rural county in Indiana, but like you start where you're at. And if you could take anything from the book, it's like read the book and learn what to do, come up with some ideas, and then do something. Like a failed attempt is so much better than a armchair quarterback, right? I mean, do something. Fail. You know what I mean? And like that could be the salute, that could be the issue a year from now. We could just shut it all down. And it's possible. But if you don't step out and do something, if you don't step out and try, then you have accepted, I think in healthcare specifically, you've accepted this death. And as much as that title pushes people away, I want you to understand like that future doesn't have to be, but it's coming if we do nothing. So that's me. Anything, Ashley?
No, this is so exciting. It's
So exciting. It's really exciting to be here and advocating for all of this. I am humbled to be here in present and get to be a part of this coalition meeting here in Indiana. And this is the example that is going to ripple throughout the United States and the world. We need to get into our communities. we need to care for our communities first and let them know who truly has their best interest at heart. And I think just kind of do it the way nurses always do things, our own way.
Yes.